Well, friends, this is our 127th webinar. Moderator today is Dr. Mukul Kapoor. Mukul Chandra Kapoor is known to you. He is a head of the department and a senior consultant and professor with Amrita Hospital, Delhi.
It's a privilege to be again there in front of all of you and to present the webinar. And we purposely took up this topic because we wanted to talk about subjects which are normally not discussed in pediatric anesthesia. And the first speaker for the day is Dr. Ketan Kulkarni. Dr. Ketan Kulkarni is a senior consultant in pediatric anesthesia at Amrita Hospital, Faridabad. He's got a lot of interest in the vascular access and the airway in the pediatric age group. He's got multiple publications, and before he joined Amrita Hospital, he was a consultant pediatric anesthesiologist in the National Health Services UK, and let me tell you, he is also a DM in pediatric anesthesia. He's from the second batch of DM pediatric anesthesia, which is a great achievement because pediatric anesthesia, when it started, that was the time when Ketan went into this field. And I would now request Ketan to make his presentation on how to approach the vascular access, central vascular access in pediatric age group. Over to you, Ketan.
Sorry,
yeah, fine. You are.
Yeah, I was mute. So thank you very much, Dr. Mukul, for that kind introduction. And today, yes, we'll be discussing about. I don't know how to go back. Yes. So yeah, we'll be discussing about pediatric central lines and how to make it safer. Most of you guys are already like practicing anesthesiologist. You are well versed with the central lines and everything. So I'll talking about the routine things like IJV and femoral and subclavian. It will be I think injustice to you. So that's why I'm going to talk about specifically about brachiocephalic vein cannulation. Personally, I feel this is less commonly approached way for cannulation or central venous cannulation. A brief anatomy about BCV is it's formed by the fusion of two big veins, internal jugular and left subclavian vein. The left-sided is relatively longer than the right-sided vein. Before I proceed, there are certain disclosures. As much as I would like to have, there are no any financial associations, and all the videos and patients you will be you will see in my presentation, they are from my previous institution, KEM Hospital Mumbai, my alma mater. So why this is central venous line is so important. This was an original research article published in 2010 in Pediatric Anesthesia, which basically discussed about risk in pediatric anesthesia. And they, apart from other factors, they also saw the cardiac arrest, how frequent it is. And they found out that almost 2.5% to 9% of the cardiac arrest are during anesthetic central venous line insertion, which is, I think, a significant number. And these complications are not because of some distant problems like sepsis or septicemia. It is because of on-the-spot problems like acute problems, maybe because of hemothorax, pneumothorax, all the immediate complications. So in order to reduce these complications, there are like various protocols have been set up, SOPs have been made, but still the problem still persists. And all this literature, all these studies are from the Western world, where there are already very strict guidelines about use of central line and asepsis and everything. So agenda for today, we'll basically discuss in two parts, the brachiocephalic vein cannulation. One is line placement per se, and then second part we'll discuss about line confirmation. Most of us will agree to this, that ultrasound guided IJV cannulation is like our first choice, especially in kids. Many of us will consider it as a gold standard. And we know this for a fact that it is difficult in less than 10 kilos. It is technically challenging even in experienced hands. There is also evidence to suggest that it is basically difficult in less than 10 kilos, and it is challenging in experienced hands. So what happens exactly? What is the problem when we are cannulating interjugular vein? When you put the probe on the patient, everything looks nice, big fat IJV carotid, but the carotid is right behind the IJV. So, and plus, if you are not holding the probe properly, if you are putting a little bit of more pressure, or you put the needle on top of, or when you try to actually puncture the IJV, everything becomes small, and then basically you are trying to drive a truck through the other market. So it becomes more challenging. Plus, even if you are then succeed in putting the needle or the cannula in the IJV, if you are not very good at follow the tip thing, or the technical word is dynamic needle tip positioning. So if you are not very good at it, you are not very sure whether you are looking at the tip of the needle or you are looking at the shaft of the needle. So if you are looking at the shaft, your tip is somewhere way down, and then it can cause again posterior puncture, hematoma, and then eventually you will not be able to use that particular side. The same thing happens with in-plane technique as well. If you are using in-plane, the carotid and IJV are on top of each other. Again, it becomes difficult. Sometimes, or for the most of the times, the probe itself is a very long, and then it covers the entire neck of small infant, small baby. Plus, you are starting your cannulation here with the cannula and with the syringe attached to it. Everything becomes very long. Technically, it becomes very difficult to use in-plane approach. Femoral and subclavian vein cannulation in small babies, the diameter is really, really small. If they are hemodynamically, if they are dehydrated or if they are not breathing properly, the size again becomes smaller. There is a risk of thrombosis because of the small size. A risk of infection, especially in femoral veins, and accidental pneumothorax is very much possible in subclavian veins. Also, when you are using subclavian veins, using ultrasound becomes very difficult to cannulate these veins, because again the clavicle comes into the way, and it basically again is a challenge. So that's why we thought that there is another way to do cannulation in small babies, that is brachiocephalic vein. When I saw the history, it was basically first introduced in around in 70s. But then at that time, obviously, it was without any ultrasound guidance, supraclavicular approach for brachiocephalic vein. But the complications were very high, so it came in and then again it phased out. But with ultrasound, it is becoming more and more common. People have started using it more now. What are the advantages? It is a larger diameter vessel because it is formed by the fusion of two relatively large veins. It stays patent even in hypovolumic state, because I think one of clavipectoral fascia is basically keeping it well inflated. I don't know what's the correct word, but it's keeping it patent. There is sufficient space for ultrasound probe. So when I was telling you about IJV, when you are putting the probe, there is not enough space there. But when you are doing brachiocephalic vein cannulation, your probe is like this. So there is sufficient space. Plus your entry and your vein is away from the oral cavity. So again, chances of infection is less. It is very easy to manage for the ICU staff. And also it is very convenient for the patient because there is no lines hanging from the neck. Visualization, you can do everything under vision. You can put the needle, guide wire, dilatation, everything can be done under vision, and we'll see in our subsequent video how to do that. So it gives you basically real-time images, and it increases the safety. So this is the video. Brachiocephalic vein cannulation. It was case of suspected TA-PVC. This is how we do it. Pre-procedural scan. You can see the trachea in the center. Right now we are scanning way up in the neck. That's why you can see the bifurcated carotid artery. Right next to it is the IJV. It's of the left side. And then we'll be sliding the probe down. Just in a second. So yeah, we are sliding the probe down, and then we are looking into the thorax. So when we look into the thorax, then you basically see this nice big brachiocephalic vein. Now, since this is a suspected case of TA-PVC, you will be able to also see the cardinal vein. That's the cardinal vein. It is a supracardiac TA-PVC, and obviously we will not, and then we'll not be putting our the catheter in there. We want to put it there. This is our standard preparation, painting and draping, then probe preparation. And this is again our final scan. Important things is don't advance the needle till you see it. That's why my colleague is doing it here. Yes. Sorry. So he has advanced the cannula into the vein. Then you will be putting the guide wire. So everything is done under vision. So you can confirm that the guide wire is going into the correct direction. It is not going into another vein. Even in very small babies, we prefer to do this. Scalpel nick, I think there is some controversy about that. And then dilatation. So again, this is done under vision. So there is any problem with kinking or catheter going or guide wire coming out. All those problems are not there. And then final fixation. So this is our technique. We initially thought, okay, we are the first one to do this. So we thought we should collect some data. This was the very initial data, and then we did some interim analysis. We found out that the success rate for right was relatively low. Left-sided brachiocephalic veins, it was more successful on the left side. And if you see, the smallest patient we did was 690 grams, in which we put the left brachiocephalic. I think there were two patients like that. When we took a closer look, again, the smaller ones, we had more problems in putting the line in. It might be because of the varied experience of the anesthetists who were putting the line. We had, from first, KEM being a teaching institute, we had anesthesiologists who were putting the line right from first year of anesthesia to people who were doing DM, who have finished DM, and then at the professor level as well. So the varied success rate, you might blame it on that. But however, when we compare this to the already published literature, the first attempt success rate in brachiocephalic vein cannulation is more than 80%, and the overall success rate is almost 100%. And in all the studies, they have said that the left side is more more easy to do it. So now we have finished about how to put it, and now we are coming to how to confirm the position. For that, I think it's very, I will just say about few basic things about echocardiography. Most of the institutes have an echo probe along with the linear probe. The linear probe is something which we use for putting the lines in, and then the echo probe is for all the phased array probe is for doing echo. If you put the echo probe into the subcostal area or near zipisternum and try to look at the heart, then you will be, it is very easy to basically acquire 4-chamber subcostal view. It is not very difficult. If I can do it, I think everyone can do it. You just need to give a little bit of effort and give us a little bit of try, and then it's easy. So this is how you place the probe. You have this echo probe. This is the same machine which we have used for putting the line in, and you put the probe near zipisternum in the subcostal area. You basically look at the heart, and then once you have achieved the subcostal 4-chamber view, you slightly rotate the probe and try to see the SVC RA junction. So this is probe in the subcostal area, slight rotation anti-clockwise, and you will be able to see the SVC RA junction. You will see an enhanced view in just in a second. So this is an enhanced view. You can see this is 4-chamber view. This is right atrium, then SVC. And this is how you do saline agitation. This is the most simplest thing. Agitation of saline can be done in different ways, but this is I feel the most simplest way. And when you inject the saline, when you squirt the saline, you look at the echo image, and you will see the fountain coming from the RA, SVC going into RA. It is bedside. There is no radiation exposure. You don't need to call the radiographer. There is no any extra cost involved into it. It's right there and there itself. This is a slow motion view. So this is in another patient. You can see something is floating in the SVC. Is it a shaft or tip? You will see here. And this is again, as we got experience in getting this subcostal 4-chamber view, we improved in our image acquisition skills, and you saw how this is much better than what it was in previous 2 patients. So again, nice right atrium, SVC you can see. There is some floating tip, and then you see nice fountain coming out of that tip. So basically this confirms that it is endovenous. So whenever you see any bubbles coming into right atrium in subcostal 4-chamber view, it confirms that it is on the venous side, not on the arterial side, or not in thorax, or it is going into some mediastinum, some abnormal position. So that's how it is confirming that it is in the venous side. However, there is like many studies published on this. People calling it as a saline flush. Some people have called it as a bubble test. Some people have called it as a RAS, or rapid arterial swell sign. Long story short, many names, the thing is the same. Like you squirt agitated saline, and see what is coming into the right atrium. If there are bubbles coming, that means it is on the venous side. But however, it doesn't confirm where the tip is, and that's why we are basically focusing more on the SVC-RA junction, and this is our publication where we saw we basically looked at the SVC-RA junction and confirmed the tip. This was again the same video. You can see the tip of the vascular catheter and the fountain coming out of it. So it gives better confirmation and where the tip exactly located is. These are a few of our patients. This was one of the smallest one, 700 grammer. Again, we did put the left subclavian vein. And suppose even if you don't have any intubation or LMA, we were like using this technique, like use a face mask and tie it, and keep the patient spontaneously breathing and do the central venous cannulation. And these are my references. Thank you very much and all the best.
Thank you, Ketan. Thank you, Ketan, for giving out the pearl points in doing central venous cannulation by a different technique. All of us are used to using basically only in the internal jugular or the subclavian or the femoral, but going by the brachiocephalic route, you have shown us that we can do something different. And I think it's very safe considering the fact that you have also confirmed it with the use of echocardiography. So I think it's a lesson learned for all, because USD machines are now available across board in almost all centers, and everybody is using them left, right, and center. It is great to be safe, and I think there's nothing better than safety in whatever we practice. So we come to the next part of the webinar, and the next part of the webinar will be presented by Dr. Priyanka Pradeep Karnik. Dr. Priyanka Karnik again is also a DM in Pediatric Anesthesia, and she's also done the European Society diploma, and she is presently working in NH-SRCC Children's Hospital in Mumbai, which is actually a relatively small place but doing great work, because I know they're doing a lot of heart surgeries there, very complex congenital cardiac surgeries being done there, and so I'm aware of that, and it's taking off in a big way. And her interest areas are pediatric regional anesthesia, pediatric vascular access. She has again got publications in very good journals, which include the Canadian Journal, the Pediatric Anesthesia. Both of them are premier journals in this, apart from other journals which are opposed there. And she's going to give us tips on how to do a safe ultrasound. Over to you, Dr. Priyanka.
Thank you, sir. So today I'll be speaking about pediatric regional anesthesia tips and tricks. So we all know that the regional anesthesia is a cornerstone of pediatric anesthesia practice. Without that, we would have a crying patient at the end of the surgery. So I recently read an article in Anesthesia Journal, which was published in 2020, which opens up with the quote by Albert Einstein that any intelligent fool can make things bigger and more complex, but it takes a touch of genius and a lot of courage to move in the opposite direction. What has happened is that with the advent of USG, there has been an onslaught of pediatric regional blocks or regional blocks in general, which are coming up, which are newer, and they have a lot of nomenclature, different nomenclature. But these blocks are being practiced by a select group or only a small number of anesthesiologists, whereas the rest of them are now becoming more and more intimidated by these newer blocks. So what this article tells that we should have a few blocks, which are our plan A blocks. These are some small number of nerve blocks, which cover a vast majority of surgical procedures. So actually this article covered both the adult as well as the pediatric patients. Then there was another article in Anesthesia 2022, which talked about these core basic nerve blocks or the plan A blocks in only the pediatric patients. So this was titled New Blocks on the Kids, which are the core basic nerve blocks in pediatric anesthesia. So let us see which are these blocks one by one. So first of all, we have our caudal block, which is like the bread and butter of the pediatric anesthesiologist, and it is one of the basic blocks. In the upper limb, they have talked about the axillary brachial plexus block. In the lower limb, the femoral as well as the popliteal sciatic block. Among the truncal blocks, they have talked about the rectus sheath and the lateral quadratus lumborum block and the dorsal penile nerve block as well. So as you can see that combined, if these blocks are combined, they will cover a large majority of the procedures which are routinely done in pediatric practice. So let us see all of these blocks one by one with the help of some clinical scenarios. So first is a 1-year-old child weighing 10 kg, a case of intussusception, who's posted for exploratory laparotomy. The second child is a 4-year-old child weighing 14 kg, a case of cerebral palsy, and is posted for bilateral hamstring PMFR, that is percutaneous myofascial release and adductor lengthening. And the third scenario is a 2-month-old infant, 2.5 kg, born at 32 weeks of gestation and posted for bilateral inguinal hernia repair. So this child is a preterm. So what would be your choice of regional anesthesia in all of these cases? My choice would be a caudal block. So in the third case, we will be able to use caudal block as the sole anesthetic agents, just giving some kind of sedation for putting the caudal block, and we can do the entire case on caudal block and not giving general anesthesia so that we avoid the risk of post-op apnea in the preterm case. So as we all know that caudal block is one of the most common blocks which is performed in pediatric practice. Around 34 to 40% of the total regional anesthesia is comprised of single injection caudal blocks. It is easy to learn, and many studies have shown that even anesthetists with no previous experience or who have not performed caudal block previously, they require about 32 blocks to gain 80% success rate. So why caudal block in children? This is because the lamina of the S5 and the S4 vertebra is unfused, creating a space called as a sacral hiatus, and that is where you access the caudal epidural space in children. So we all know that in infants, the spinal cord ends at S3 and the dural sac ends at the spinal cord ends at L3 and the dural sac ends at S3, as opposed to L1 and S3, L1 and S1 in adults. So while giving position, we have to be careful that we give the left lateral decubitus with the hips and knees flexed, because what happens when we flex the hips and the knees of the child, the dura as well as the spinal cord, they tend to move little bit upwards so that we avoid injuring the spinal cord as well as the dura when we are accessing the caudal space. So what is the landmark? Landmark is the posterior superior iliac spine, which create dimples. So these two posterior superior iliac spine would be the base of an equilateral triangle, and the apex would be the sacral hiatus. Sacral hiatus, it will be bound by the two sacral cornua, and that is where we would be entering the caudal epidural space. So the needles which we use are either the 22 or the 23 gauge hypodermic needle or the stellated needles, which are the Crawford needles. If they are available, we can use those as well. The skin is pierced at an angle of 45 degrees till you get a pop of the sacrococcygeal ligament, and then the angle is lowered to enter the caudal space. What are the drugs injected? They can the drugs injected are 0.25% bupivacaine, or you may use 0.2% ropivacaine, and we can add 2% lignocaine in this mixture for faster onset of action. Additives can be clonidine, 1 to 2 mics per kg. We usually use clonidine or morphine in children who are more than 6 months. Morphine is not used as much, but we routinely use clonidine, 1 to 2 mics per kg. Now, how do we confirm the correct injection? So first of all, there will be negative aspiration of blood as well as CSF. Then there will be no resistance to injection of the drug. Again, we have the swoosh and the whoosh test. Now, the whoosh test was first discovered in 70s or something, 70s or 80s, I feel, where they would inject 2 to 3 cc of air into the caudal space and then auscultate with a stethoscope placed proximally on the spine. But because there were chances of hemodynamic instability and because there was patchy analgesia, so this was actually converted to the swoosh test, wherein instead of air, the drug itself was injected and the swoosh of the drug was auscultated proximal to the site of injection. So now we routinely don't practice this whoosh or whoosh test. We may use USG for confirmation of proper placement. It is easier in infants because the vertebral bodies, they are not ossified in them. So when we have to do the USG confirmation, then we place the linear probe slightly paramedian in position, and this is what we see. So this will be our spinous processes. We may be able to see some pulsation of the spinal cord, and this is how the caudal space opens up when we inject the drug. Now in infants, because the secondary curvatures of the spine are not developed, once we have created the space, we may also be able to put in a catheter. So here, as you can see, that the caudal space has been opened up and you'll be able to see the epidural catheter walking in. So we have put these caudal catheters in infants for biliary atresia procedures as well. Now, when you're giving a caudal block, you have to be very aware of the amount of drug you're injecting, because that is going to decide the level till which your block is going to act. So be very mindful of how much you're injecting. So for lumbosacral levels, so if say we are going for a hypospadias procedure or any rectal procedures or anal procedures, then we need to give 0.5 ml per kg of drug. But say the child is posted for an open orchidopexy or even a hernia, because there is going to be some pull of the peritoneum. So we would require a low thoracic level. So 1 ml per kg of 0.25% bupivacaine needs to be given. And suppose we are going for an exploratory laparotomy where we are going to require a higher thoracic level, then we need to give 1.25 ml per kg of drug. So this covers our very basic block, that is a caudal block. But what if we are not able to access the caudal block? Or we all know that now we are moving away from the central neuraxial blocks. We are moving towards the truncal blocks. We are moving towards the blocks which are not actually accessing the central neuraxis. So which are those blocks which we can use and which are easier also to do? So let us see one case scenario. So this is a 4-month-old male child weighing 4 kg. Is a case of gastroesophageal reflux disease and was posted for gastrostomy and fundoplication. Now the incision was at the midline at the epigastrium, but the caudal space could not be accessed. So what could be your choice of regional anesthesia here? My choice would be a rectus sheath block. Now let us see what is a rectus sheath block. So this is used for surgeries around the umbilicus, that is umbilical hernias, for the umbilical laparoscopy port, for IHPA surgeries, and for fundoplication. This is a truncal block basically, and bilateral blocks are required for covering the entire umbilical region. The injection of the local anesthetic is between the rectus muscle and the posterior rectus muscle sheath, and it gives good periumbilical anesthesia in the T9 to T11 dermatomes. So when you keep the probe just above the umbilicus in the midline, you'll be able to see the linea alba in the center and the 2 rectus muscles on either side. The rectus muscles are the muscles which form actually your 6 packs. So when you shift the probe a little bit laterally, you'll be able to see the single rectus muscle. Now what you have to ensure is that you have a very shallow trajectory when you are entering the space, because there is a high chance that you may injure the peritoneum. So we will see the needle has to be entered in a very steep plane, and you have to visualize the needle at all times. The tip of the needle should be visualized at all times. Now, when the drug is injected, you have to see first whether the drug is going in the muscle or it is going in the plane between the muscle and the posterior rectus sheath. Once you have made the space, you can now advance the needle further and then inject the total amount of drug. So around 0.2 to 0.5 ml per kg of 0.25% bupivacaine gives a good coverage. If you give a higher amount of drug, that is 0.8 ml per kg or so, it can give coverage from the xiphoid to the pubic symphysis. Now let us come to the lower limb blocks. So among the lower limb blocks, this article mentions the femoral as well as the popliteal sciatic block. So first let us see the femoral block. Now, if you have an 11-year-old female child, we recently had this case actually. She was a known case of mucopolysaccharidosis 4, and she was posted for right knee growth modulation. That is, they were going to put a PET screw on the medial side of the knee. Now, this child had a thoracolumbar scoliosis. The child had macroglossia. She had previous history of difficult intubation. She was done at KEM hospital itself. So, with time, the airway had become even more difficult. The macroglossia was significant. So we wanted to avoid giving her general anesthesia altogether. So what would be your choice of regional anesthesia in this case? Now remember that the PET screw is going to be inserted on the medial side of the knee. So my choice would be a femoral block. So femoral block, it will cover the anteromedial thigh, and it will be useful for surgeries of the femur, patella, quadriceps, knee surgeries, and analgesia for the hip fractures also. The lateral aspect of the the thigh is paired, but if you block the lateral femoral cutaneous nerve, then even that can be covered. So what are the landmarks? Now we need to keep the probe at the inguinal crease with the patient supine. The nerve is anisotropic, so visualization is improved by tilting the probe either cranially or caudally. And the structures which will be seen from medial to lateral are the femoral vein, the femoral artery, and then the femoral nerve. This femoral nerve is between the two layers of the fascia iliaca. So whenever you access the femoral nerve, you have to actually pierce the fascia iliaca. Otherwise, you will be just depositing the drug around the femoral artery. And needle entry should be from the lateral to the medial side. So this is one of the most easiest blocks. Earlier, it was performed with the help of your nerve stimulator. So there, the patellar snap was the landmark. But now, because of the USG, it is becoming even more easier to localize the nerve. And this is a big nerve. So there is no problem in visualization of the nerve also. The next scenario is a 10-year-old male child. He is a known case of arthrogryposis multiplex congenita with lumbar scoliosis posted for left foot reconstruction. Now again, here because of the scoliosis, we will not be able to give the caudal block, so or the epidural also. So what will be your choice of regional anesthesia? So here we will be going for a popliteal sciatic block. So popliteal sciatic block, it gives anesthesia of the entire distal 2/3 of the lower extremity with the exception of the medial aspect of the leg. So the foot, ankle, and the Achilles tendon surgeries are all covered with this popliteal sciatic block. We have to remember that the sciatic nerve will divide into the tibial and the common peroneal nerves just 2 to 3 centimeters proximal to the popliteal fossa crease. So when you want to give a popliteal sciatic block, so try to go as proximal as possible where the nerve has not divided. So patient is placed in the lateral position with the affected limb placed up, and we scan from the popliteal crease upwards. Popliteal vessels, they serve as a landmark. So here we can see the popliteal artery, the popliteal vein, and the nerve, sciatic nerve. It has not branched, as you can see. So when you're injecting the drug, now here we are not able to visualize the entire needle, but you can see the indentation. Our goal is to create a nice donut of local anesthetic around the sciatic nerve. So here you can see the local anesthetic drug being injected. So try to get as much as drug as possible around the nerve to get the best possible block. So this femoral and sciatic combined, it actually covers most of your lower limb. Now in the upper limb, we have the simplest block, which is the axillary block. So we all know that we can block the brachial plexus at the root level, at the trunks, at the level of the divisions, cords, and terminal branches. So our axillary block is going to block the terminal branches, that is the median, ulnar, and the radial nerve. What we have to be mindful of is that we have to avoid the axillary artery. So hence, USG actually helps us a lot, and it can be supplemented with the musculocutaneous nerve block for tourniquet pain. So again, it is used for the surgical intervention of the hand, wrist, forearm, and elbow. So anything below the elbow, you can cover with the help of your axillary block. And we all know that the median, ulnar, and radial nerve, they're all around the axillary artery. So the median will be like slightly lateral, ulnar will be medial, and the radial will be posterior or seen below the axillary artery. So the patient will be placed supine with the hand abducted and externally rotated, and the probe will be kept in the axilla longitudinally and will be entering the needle in the in-plane technique. So in the in-plane technique, we'll be able to see the axillary artery, and the needle can be inserted downwards and upwards. So we make local anesthetic donut around this axillary artery. So here we can see the shaft of the needle. Here also it is important to visualize the needle tip at all times because the vessels are quite superficial. So here we can see the local anesthetic being deposited around the axillary artery, and we'll also try to go below the artery so that it is lifted up and the local anesthetic spreads around the artery. You may not always be able to visualize the nerves, but even if you can visualize the vessels and deposit around it, it will give you a good analgesia. Now let us come to the truncal block. Let us see one more scenario. She is a 9-year-old child, a known case of common cloaca with an abdominoperineal pull-through done, and she was posted for colostomy closure. She had undergone multiple surgeries in the past. However, MRI shows a syringomyelia of the cord with partial sacral agenesis and vertebral anomalies. Again, the epidural space is out of bounds for us. So what would be our choice of regional anesthesia over here? We would have definitely liked to give an epidural block, but since we are not able to, we would go for a quadratus lumborum block. Now, quadratus lumborum block is a slightly complex block. You cannot actually call it a plan A block, but if we gain that expertise, we will be able to perform that. Now, there are 3 types of quadratus lumborum blocks. I'll come to that. Now, it gives somatic as well as visceral analgesia for the abdominal surgeries, and it gives an extended sensory blockade between T4 to L1. The efficacy is because of the spread of the local anesthetic into the paravertebral space. So what are the 3 types of blocks? Now, earlier there was a nomenclature of QL1, 2, 3, 4, but it created a lot of confusion. So now they have changed the nomenclature. We have the transmuscular or the anterior QL block, then we have the posterior QL block and the lateral block. So let us see what all of these mean. So highest success rate is with the anterior approach, but we have to be cautious regarding the possibility of kidney injury. So the lateral QL block is where your tap muscles, that is the abdominal wall muscles end, that is your external, internal and transversus will end, and the QL will start. So there you have to give the lateral QL block. The anterior QL block is between the QL and the psoas muscle. Now to remember, QL is, that is a quadratus lumborum is a hypoechoic muscle. So just remember that, and on the basis of that, you will be able to differentiate between the various muscles. And it is anterior. So the posterior QL block is behind the QL muscle here. So we'll be able to see better in this image. So here you can see that this is the transverse process, this is the QL muscle, and this is the psoas major muscle. So the patient has to be placed in the lateral position, and the probe is placed between your costal margin and the iliac crest. Now while injecting, you can see that the needle is approaching, will pierce the QL muscle, which is the hypoechoic muscle here. This is the transverse process. After piercing the QL muscle, we need to go in between the psoas muscle and the QL muscle. So let us see the local anesthetic being injected into the space. So this is how the space will open up. Now this is also the landmark for lumbar plexus block, because you will see this exactly the same picture. You will be seeing the transverse process, you will be seeing the psoas muscle, and the lumbar roots will exit from here. So this article actually does not mention the tab block, but I must say the tab block is even more easier than your QL block, and it will give analgesia of the abdominal wall, though it will not give any visceral pain relief, but it will definitely give somatic pain relief. So tab block is basically a block between the internal oblique and the transversus muscle. So you're giving the block between these 2 layers. This is the external oblique, this is the internal oblique, and this is the transversus abdominis. So let us look at this block as well. So here the needle has been inserted, and now it is in between the internal oblique and the transversus abdominis. Here again, the needle tip has to be visualized at all times. And what we want to do is want to unzip the internal oblique and the transversus abdominis. So here we'll be creating a space. And as the space is created, we can advance the needle and further open up. So this will actually cover your entire abdominal wall if given correctly. My last scenario covers a 9-year-old boy posted for distal hypospadias repair, a 3-year-old boy posted for circumcision. So the obvious choice, if you don't want to give a caudal, would be the penile block. So what are we blocking exactly? So the pudendal nerve, it divides into the right and the left dorsal penile nerves, which travel under the buccal fascia. The surgeries which can be covered are circumcision, urethroplasty, glandular hypospadias. The main thing to remember is to avoid adrenalized lignocaine or addition of adrenaline to the local anesthetic solution, because these are end arteries. So how do we give it? First is your blind method. So here we insert the needle perpendicular at the 10 o'clock and 2 o'clock position at the pubic tubercles, or we can give it through a single injection at the midline and sweep the needle sideways, but we have to avoid the deep dorsal vein. So after hitting the pubic tubercles, you withdraw the needle by 1 to 2 millimeters and you deposit the drug there. As little as 0.1 ml per kg of 0.25% bupivacaine or ropivacaine can suffice. Now this block can be given by ultrasound also. This is an overkill, but still to mention it, a high frequency probe is placed at the base of the penis, and the landmarks which are seen will be your deep dorsal vein, your the dorsal artery, and your nerves. So first in the center we will be seeing the corpora cavernosa, and in the center will be your corpus spongiosum. So what we have to do is we have to penetrate the buccal fascia and you have to deposit the drug between the buccal fascia and the tunica albuginea. So even if you don't do it ultrasound, you can safely do it with the help of your landmark technique. Just palpate the tubercle and deposit the drug. So as I have mentioned, so all these are the plan A blocks, which need not require a great expertise. These are the blocks which you should know, which will help you in your regional anesthesia techniques in the entire pediatric anesthesia practice. So I hope that I have given you some tips and tricks regarding which blocks to use in which patients and which patients to avoid giving your central neuraxial blocks. Thank you.
Thank you, Dr. Priyanka. That was a very simple and a very good presentation, giving out all the salient features and in a very simplified manner. I'm sure all the people who have been attending have benefited from this, and they will try to practice it in their day-to-day surgeries. It's thank you very much for an excellent, a very excellent presentation on this.
Thank you. Thank you.
And so we now move to the third topic. Third topic is something which, is on patients with non-cyanotic heart disease coming for surgery, which is a very common thing today. We find so many patients with VSDs, with ASDs, or with PDAs who come for different kinds of non-cardiac surgery, especially children coming for hernias, hydrocele, and it confuses the poor anesthesiologist how to manage such patients considering the shunts which are there. And to make the matter simple for you, we have Dr. Jitin Narula talking about this. Jitin Narula is the DM in cardiac anesthesia. He's a consultant cardiac anesthesiology at Amrita Hospital, Faridabad again. He has a lot of interest in transesophageal echocardiography and hemodynamic monitoring. He is also the recipient of our association, the Cardiac Association Award, that is Ayakta Kabir Award in 2016, the Young Investigator Award by the International Society of Blood Transfusion, Harold Gunson Fellowship also he has received from the International Society of Blood Transfusion, and he has also received the ICMR International Travel Grant for young ICMR scientists. At this young age, he's got 30 publications, which is a huge number. And I think one should compliment Jitin for his academic work. He's been doing a lot of academic work, and to present again, not a very difficult subject to make it, but even make it more simple. It is Jitin Narula who will talk to you about acyanotic heart disease in children for non-cardiac surgery. Over to you, Jitin.
Thank you so much, sir, for your kind introduction. And I'm sure that I am first of all thankful to you for giving us this opportunity and for pushing us for taking all these academic sessions, which not only help others but help us evolve as a better anesthesiologist. Thank you, ICA, for bringing all of us together again for another academic session. I will be highlighting about acyanotic heart diseases in children and in situations where they're presenting for non-cardiac surgeries. So as Mukul sir just highlighted about the situation of children coming up for surgeries and having presence of a congenital heart disease, it's because it has a pretty high incidence of around 8 to 10 per 1,000 live births, and in incidence in India being around 19.4 per 1,000 live births. Premature infants have a much higher incidence, and why we are very concerned about such patients presenting for surgeries, because any child with an uncorrected congenital heart defect is at an increased perioperative risk. We will be discussing most of the risks during the next course of this session. So this lecture is about understanding the physiology of left to right shunts, recognize the associated risk, stratify these patients into high and low risk patients because anesthesia-related pediatric cardiac arrest and morbidities, according to a recently published review, is almost 75% patients undergoing under 2 years of age who are undergoing major non-cardiac surgeries. We will highlight upon principles underlying the management, briefly come over on pre-operative assessment, anesthetic management, post-operative care, and just a hint about the anesthetic pharmacology. So what are left to right shunts? Mostly they are pathologies which have a basic mixing of the oxygenated and the deoxygenated blood. Anatomically, they can happen at 5 levels. At the level of the atria, where it can be an ostium primum or ostium secundum ASD or patent foramen ovale. At ventricle level, it can be a ventricular septal defects. At endocardial cushion levels, it can be an atrioventricular septal defect. At the level of the great arteries, it could be a patent ductus arteriosus, an aortopulmonary window, truncus arteriosus, and minor level of shunts at the level of coronary arteries like coronary fistulas or anomalous left coronary artery from pulmonary artery. So basically, left to right shunts have an increased, the blood flows from a region of high pressures to low pressures. Pulmonary circulation is at low levels. So we have a condition of an increased pulmonary blood flow. This leads to an increased shear stress and circumferential stretch in the pulmonary arteriolar system, leading to endothelial dysfunction and vascular remodeling. This leads to smooth muscle cell proliferation, increase in extracellular matrix, and minor intravascular thrombi, which then subsequently leads to increase in pulmonary vascular resistance. This may be initially in a reversible state, but if it is prolonged and uncorrected, it leads to in later stages, it becomes fixed and irreversible. And subsequently, it may lead to an inversion of the shunt from left to right. The pulmonary vascular resistance becomes suprasystemic, becoming higher than systemic vascular resistance, leading to a right to left shunt with causing cyanosis, which is an end stage condition called as Eisenmenger syndrome. So as I just said, the 3 most common presentations are ASD, VSD, and PDA, but they are all left to right shunts. They have minor differences. Let's discuss briefly. The shunt in the atrium at the level of atria causes blood flow from left atrium to right atrium, and the right-sided circulation, the right atrium and the right ventricle is under a volume overload. So the right atrium RVVO is pronounced in ASD. Whereas in ventricular septal defects, the shunting is from the left ventricle to the right ventricle during the systole, and the RV cavity is very commonly bypassed. So it produces a more of a left-sided volume overload rather than a right-sided volume overload. In the earlier stages, we would find that the left atrium and the left ventricle is larger and has a volume overload condition, with the right ventricle having a hypertrophy, secondary to the elevated pulmonary artery pressures. In the patent ductus arteriosus also has a condition of the left ventricle volume overload. Besides a condition in this, there is a decrease in the aortic diastolic blood pressure due to the backward flow from the aorta to pulmonary artery, and leading to decreased coronary perfusion due to a decreased diastolic blood pressure. And this predisposes them to myocardial ischemia if there is a hypotension in these patients. This is known as a diastolic runoff. These are seen in conditions like at shunts at great artery levels like PDA, truncus arteriosus, and AP window. Besides the anatomical classification, what is important to have an understanding of the pathophysiological classification, because this enables the anesthesiologist to anticipate the changes that the anesthesia strategy will have on hemodynamics. So the shunting will be of 2 types. The first one would be a restrictive shunt. These are seen in small shunts, and this is called a series circulation. The shunting is usually fixed and low to moderate in volume. There are minimal clinical implications in the situation, and the predominant blood flow is that of a structurally normal heart. So these shunts, the shunts which are usually small in size, and they are unaffected by changes in the systemic vascular resistance or the pulmonary vascular resistance. The degree of shunting here depends both on the size of the defect and the pressure gradients across it. What we are more concerned about as anesthesiologists in perioperative situations are non-restrictive defects or the larger shunts. These are also called the balanced circulations. That's because the large cardiac defects causes complete mixing of the deoxygenated and the oxygenated blood. The 2 circulations are not separate, and the pulmonary and blood flow and the systemic blood flow in these situations is determined the difference between the vascular resistance and the systemic vascular resistance. So excessive blood flow to any one of the area will compromise the blood flow to the other area. A high pulmonary blood flow to systemic blood flow, or the QP by QS ratio, causes high pulmonary blood flow, causing pulmonary edema and pulmonary artery hypertension. Whereas a low QP by QS results in flow from the pulmonary side to the systemic side, resulting in cyanosis. So it's very essential in these patients to maintain the balance between the pulmonary vascular resistance and the systemic vascular resistance. We must be aware of various factors which can affect the pulmonary blood flow, like increased pulmonary vascular resistance can happen secondary to hypoxia, hypercarbia, acidosis, hyperinflation. All these settings are very common during the perioperative events, and a fall in the SVR, which can happen to mild even pyrexia, which happens post-operatively or during the course of any surgery that the patient is undergoing, or as an effect of systemic anesthesia like anesthetics like propofol or any other agent which can cause a decrease in SVR, and of course because of sympathetic blockage. So we need to be very careful about pulmonary and systemic vascular resistance ratio in these patients who are having balanced level of circulation. So the Eisenmenger syndrome, as I said, is an advanced stage of disease and eventually happens when there is a shunt reversal secondary to suprasystemic pressures. This pulmonary vascular resistance is almost fixed, and it's a non-reversible PAH usually happens. And these are the patients who are the most challenging anesthesia situations. So mostly, when do we encounter such patients? Can ideally happen for any procedure, but mostly we encounter them when they are coming for any imaging, cardiac catheterization surgeries that are associated for congenital anomalies that are very commonly seen in these patients. And almost 30% amongst these might require surgery during first year of life due to extra cardiac anomalies like tracheoesophageal fistula, anorectal abnormalities, hernias, cleft lip, palate, and renal and skeletal anomalies. They may even present for emergencies like tracheoesophageal fistula, emergency abdominal or neurosurgeries. What is our preoperative about? It's about understanding having a knowledge of the underlying lesion, identifying any long-term complications, identifying any recent upper or lower respiratory tract infection. I'll be discussing about venous access may be difficult, the drug therapy that they are on, and managing their sedation and endocarditis. So preoperative assessment is basically targeted at assessing the physiological status with an aim to rule out 4 major risk factors. First is the presence of cardiac failure, as almost 10% of patients in cardiac failure suffer cardiac arrest, and 96% require perioperative inotropic support. Presence of pulmonary hypertension must be ruled out, as these children are 8 times more likely to experience a major complication. Arrhythmias are very common, and we must identify patients with the congenital heart disease having arrhythmias. That 30% of children with ventricular ectopics may die suddenly. And presence of cyanosis and its complications must also be ruled out. So we go ahead with a detailed history, which is very commonly encountered is frequent chest infections and pneumonias, recurrent respiratory tract infections. If they are present, we must document when was the last episode. These children usually complain of easy fatigability, exercise intolerance, palpitations. In children of lesser age, the parents usually complain of feeding diaphoresis or distress feeding, which is secondary to decreased exercise tolerance, or and they usually have failure to thrive. In advanced stage of disease, they may have abdominal distension, ascites, and cyanosis. Anesthetic history is very important in these because details of previous intensive care admissions should be obtained, because prior episodes of prolonged ventilation means that they could be having a tracheal stenosis and a difficult intubation. Moreover, the previous anesthetic exposures may make intravascular access to be a difficult situation for the anesthesiologist. Most of them may also have associated anomalies, which may indicate a chromosomal abnormality like the trisomy 21, Dye-George syndrome, Tau-Charge, and other congenital syndromes. Down syndrome patients have atlantoaxial occipital subluxation that will warrant airway management precautions and risk of bradycardia on sevoflurane induction. So we need to be very careful about patients who are syndromic. medication history in these patients is very important because they may be on multiple drugs for heart failure, for rhythm abnormalities. They may be on ACE inhibitors, which increase the likelihood of hypotension on induction. And so in quite of situations, for major surgeries, it is better to withhold on the morning of surgeries to avoid volume shifts. Patients could be on aspirin, which should be stopped in discussion with the surgeon and cardiologist. They could be on rate control medications like digoxin and beta blockers, predispose them to heart rhythm problems. And if patients could be on pulmonary hypertension therapy, which can predispose to perioperative hypotension. So anesthetic provider must be mindful of all side effects of all these medications before taking up any such case for surgery.
Jitin, you've got unshared. You have to share again. Yeah.
Jitin, you are muted. Yeah.
Sir, am I audible now?
Yeah.
Yes.
It got disconnected because of network problems. I'm sorry. I hope the screen sharing is functional now, sir. Am I audible, sir? Can you please confirm?
Yes.
Okay, I'll proceed, sir. So we must on physically examine the child and rule out respiratory distress, accessory muscles, nasal flaring, murmurs, crepitations, which are all signs of child being in cardiac failure, and always check for the room air saturation and rule out any cyanosis and look out for signs of edema like pedal edema, sacral edema, dilated neck veins, hepatomegaly, and ascites. All this we are basically doing for coming to a risk stratification and classify the patient to which risk subset basically the patient belongs to. So if the patient has a physiologically poorly compensated status or presence of any of these major complications like heart failure, pulmonary hypertension, arrhythmias, cyanosis, or presence of complex lesions, or is posted for a major surgery, is under 2 years age, has an emergency surgery, or has a preoperative hospital stay of more than 10 days, and has a poor ASA status of 4 or 5, then we classify them as a high risk for perioperative complications, or it may be an intermediate risk or a low risk patient where it is usually physiologically normal or well compensated simple lesions for minor superficial surgeries more than 2 years of age, which are elective and ASA 1 to 3. There are also other scoring systems available for this one was given by Mossad et al., in which the points are given for various types of pathologies and their PO2s and hematocrits, and it's a complicated score, but it helps to identify patients who are at high perioperative anesthesia risk who should be admitted in the ICU, or differentiate them from low risk patients who can be managed on an outpatient basis. So this is also a very valuable scoring system that can be used to stratify our patients presenting for surgery. Preoperative blood investigations always obtain a full blood count. Hematocrit is essential because the patients could be polycythemic, and it has its own side effects of increased blood viscosity, thrombosis, infarction. They could be having anemia of chronic disease and leukocytosis for infection. Obtain an RFT for patient on diuretics. PT-INR if a patient is either polycythemic or cyanotic or on anticoagulation. And liver function test is required if the patient is suggestive of heart failure symptoms. And CRP if there is an associated chest infection is suspected. Calcium in blood glucose, we would get it done for newborns or those who are in critically ill condition. ECG is suggestive in these patients of chamber enlargement. As I said, our RA and RV enlargement would be seen in patients of ASD, whereas left ventricular enlargement and system would be seen in patients with the VSD. Right bundle branch block is usually common, and secondary and ventricular ectopics can be seen in patients who are in decompensated state, and it's an ominous sign. Chest radiography should also be done, and it indicates heart position, size, whether there is any atelectasis, there is any heart failure, there is acute respiratory infection. All these things can be ruled out, and presence of prominent bronchovascular markings will be suggestive of pulmonary artery hypertension. And we can also find out if there is any LA enlargement in these cases. Echocardiography is always usually present, and it can help us with the exact anatomical defect, the direction of shunt, whether left to right, right to left, well, what is the ventricular function of each ventricle, left ventricle, right ventricle, what is the dilatation status, what is the valve function, pressure gradients across valve, and very importantly, pulmonary artery pressures. In left to right patients are very important. Any pressure, systolic pressure of mean PA pressure of more than 25 is considered to be PAH with mild, moderate, and severe classification. Mean PA pressure of more than 55 is severe PAH. Cardiac catheterization data could be available, but it's not necessary that all the children presenting have a cardiac cath done, and it can be very helpful in finding the site of side defect, the degree of shunting, exact chamber pressure, oximetry, and QPQS ratio. A cardiology evaluation may be required, and the need for cardiologists actually depends on the complexity of the lesion. In patients who have a simple lesion that has been completely corrected or is well compensated, a standard pre-anesthetic visit without a cardiology consultation is acceptable. Whereas in patients who have moderate, severe, or complex lesions accompanied with inability to compensate will warrant a perioperative cardiologist evaluation and optimization. And patient with active chest infection, which we very commonly see, is that if the patient has a chest respiratory infection, delaying a surgery should be considered, because these patients with pulmonary artery hypertension are at an increased risk of morbidity. But the decision to delay the surgery must be discussed with the surgeon to weigh the risk versus benefit. We must also have a thorough history of presence of fever, poor intake, CBC, leukocytosis, and CRP, and all these things can indicate the presence of an active infection, and all these things must be done before cancelling or postponing a case. And if the surgery is unavoidable, we must consider going ahead with high risk of respiratory morbidities due to hyperreactive airways, and with perioperative antibiotics, nebulization, and post-operative ICU stay to be considered. So proceeding to anesthesia, planning is very essential. High-risk children require a tertiary care center, because full pediatric intensive care and cardiology services may be required. Low-risk children can be managed at local hospitals. Very stable patients with stable shunts can be managed on OPD or daycare basis, but moderate to severe level shunts should be ideally admitted overnight. Fasting instructions, it's important to avoid dehydration in these patients, more so if they are cyanotic. Intravenous hydration may be recommended if the surgery timings are flexible or not sure, and a thorough team briefing should be done for enhancing patient safety. Goals of anesthesia would be to maintain systemic vascular resistance, pulmonary vascular resistance ratio, to maintain a favorable pulmonary to systemic blood flow. We would try to maintain contractility and avoid dehydration and maintain a preload. Pre-medication is essential because stress and anxiety is neither physiologically nor psychologically desirable. Sympathetic stimulation will cause increased oxygen consumption and myocardial work, and it's poorly tolerated. Monitored sedation with oral intranasal or IV midazolam is preferred, and other agents like perichloril or phenargan can also be used. However, be mindful of over-sedation, because it may cause hypoventilation and hypercapnia, which can be very nasty and can lead to precipitation of PA crisis. So anesthesia techniques, there's little evidence to recommend one technique over the other, but it's important to have a thorough understanding and impact of commonly used anesthetics. Propofol and ketamine are the two most commonly studied agents, and be mindful that propofol dramatically reduces SVR and mean arterial pressure. And in children with right to left shunts, it may cause a significant reduction in oxygen saturation by causing further worsening of the right to left shunt. Ketamine is usually preferred because of its minimal effect on SVR, mean arterial pressure, PVR, and pulmonary artery pressures, and it's the agent of choice when a reduction in SVR is undesirable or in children with pulmonary artery hypertension. Gasian induction with sevoflurane is common in pediatric practice, but be careful of these are high-risk children, and they should be avoiding prolonged inspired concentration of 8%. Patients and lower concentration is usually sufficient, and we should be cautious with gaseous induction in patients with heart failure and pulmonary hypertension. Nitrous oxide is preferably best avoided because it may cause macro bubbles to expand and cause dangerous hypoxia to happen. And important to have an understanding of various commonly used anesthetics, intravenous and inhalational, with their effect on SVR, PVR, contractility, and heart rate. It's tough to be going through all that in this session. And so we'll be moving on to monitoring. It depends on the type of surgery which we will be undergoing, and the child will be undergoing, and the patient profile. All patients must have routine ECG, SpO2, and NIBP, and airway pressure and MAC for all patients on anesthesia. Invasive arterial lines for patients who are identified as high risk or moderate risk with CHF, LV dysfunction, arrhythmias, or cyanosis, and consider volumetric urine collection, multi-site temperature monitoring, and CVP monitoring, and TEE in very high-risk cases. Key points of induction is that induction time is usually a precarious situation in which there is hyperventilation, increase in SVR can happen, and increase in left to right shunt can happen, which can cause dangerous So it's important to keep in mind regarding the mode of induction, the speed of induction. The right to left shunts, the intravenous induction is rapid in comparison, as the intravenous agent travels in blood that bypasses the lungs and enters the systemic circulation, where it is quickly distributed to its site of action. Inhalational induction in patient with right to left shunt on the reverse is slowed, as the shunted blood, which contains no anesthetic, dilutes the partial pressure of anesthetic gas in the blood that underwent the gas exchange. Left to right shunts have little effect on inhalational induction. Intravenous induction may be slightly prolonged due to continuous dilatation in the pulmonary circulation. It's important to make sure that the lines are adequately de-aired, no matter the directionality. De-airing is essential to avoid potential air embolism. Aspirate before administering any drug and keep the syringe always vertical. Certain clinical situations which we need to be very aware of are pneumoperitoneum. Gas insufflation rate should be slow. Request for lower intra-abdominal pressures. We must always adjust for ventilation to prevent CO2 retention. These are situations of high SVR due to excessive intra-abdominal pressure, which should not be allowed to happen. Low threshold should be communicated to relieve pressures or convert to an open procedure. Avoid steep Trendelenburg and head elevation, as both of these will alter the preload, causing it to either increase or decrease precipitously. Tourniquet surgeries, we need to be mindful of the elevation in systemic vascular resistance during the clamping of the tourniquet, and release time is also crucial, second, due to reperfusion and release of metabolites. Daycare procedures like dental sedation, upper or lower GI procedures, and diagnostic procedures in restrictive shunts, we can do them as daycare by providing balanced anesthesia with ketamine, fentanyl plus minus dexmed, ensuring that maintaining hydration, avoiding hypoxia, hypocarbia, and monitoring post-procedure. Unrestricted shunts, I should ideally be admitted and proceeded. High-risk cases with heart failure, as I said, that gaseous induction should be, induction times will be prolonged. We need to be patient, avoid prolonged use of 8% sevoflurane. Propofol can cause precipitous decrease in cardiac output, so ketamine is the agent of choice. Venous access may be difficult, and we must have an experienced anesthesiologist ready with to help with the IV access. And we must always be prepared with inotropes, vasoconstrictors, and inodilators in these cases. PA crisis, as I said, may happen in children with moderate to severe pulmonary artery hypertension. An anesthetic goal in managing such a patient is to ideally prevent the increase in PVR and prevent depression of myocardial function. So correct hypoxia, hypercarbia, acidosis. Treatment is with high FiO2. We must always have inhaled nitric oxide available with us. IV prostacyclins and inotropic support of the right ventricle should also be available. Maintenance phase, isoflurane and sevoflurane are usually for maintenance, is widely reported. Both agents have minimal effect on myocardial contractility or shunt. MAC of 1 to 1.5 is usually well tolerated with no effect on QPA-QS ratio. And one can use any agent which the person is familiar with. Tiva with propofol is another option, but be mindful of the reduction in SVR and the concerns of propofol-related infusion. Dexmed infusion is increasingly be used for maintenance phase, but fall in heart rate and systemic blood pressure must always be watched for. Endocarditis prophylaxis is one thing which you must never forget. and it is recommended in any patient who's undergoing a gingival tissue is manipulated or periapical region of teeth or perforation of oral mucosa is happening, and prior history of patients who have prior history of infective enterocolitis, non-repaired cyanotic congenital heart disease, complete CHD repair within previous 6 months, and repaired congenital heart disease with residual defects. It is no longer indicated in patients with AS, MS, symptomatic mitral valve prolapse, or for genitourinary and GI procedures, or procedures like TEE or gastroscopy or colonoscopy. Certain intraoperative complications which we need to be mindful of are arrhythmias, fluid overload, bleeding, sudden cardiac arrest, stroke from right to left shunting, and hypoxia. If hypoxia is happening, must always rule out pulmonary artery hypertension crisis happening, or a reversal of shunt, or an excessively reduced SVR causing a right to left shunt, or a excessively increased pulmonary vascular resistance. So all these things need to be carefully managed and be watchful of. Pain management is a critical part of anesthesia strategy, and tachycardia and excessive work of breathing should be avoided as they cause myocardial stress. Alveolar hypoventilation due to pain can cause hypoxia and CO2 retention and worsen PAH. So we must have a thorough analgesia strategy for intraoperative and postoperative procedures, and it's usually opioid based as intermittent bolus or infusion or patient control anesthesia for major procedures. Regional anesthesia for well-compensated patients with heart disease is reported with no added complications, and various blocks have just been discussed by the previous speaker. Post-op considerations, even with favorable outcome, many patients with heart diseases coming for non-cardiac surgery are still under high risk because of the shunt, and observing them in HDU or ICU may be required. And that's primarily because early detection and treatment of arrhythmias, cardiac ischemia, low output, dehydration, pain, and PA crisis is essential in the perioperative settings. So to conclude, it's very essential nowadays to maximize patient safety. And so for this, we need to carry out a thorough preoperative assessment, have a good understanding of the anatomy, the pathophysiological state, and the risk factors that are associated with perioperative morbidity. We must be prepared for potential effects of general anesthesia. A sound knowledge of anesthetic pharmacology in relation to the abnormal physiology is required, and we must always stay alert to potential complications for a successful outcome. Thank you. Feel free to ask further questions.
Thank you, Jitin. Thank you, Jitin, for a very extensive presentation on acyanotic congenital heart disease. I would like to emphasize one thing which Jitin, of course, mentioned very clearly, is that more and more surgeries today in pediatric age group are done by laparoscopic way. And these are the conditions in acyanotic heart disease. It increases SVR, increases the problems in left to right shunt. And because it increases the shunt value in left to right shunt. And so it's very important to ensure that you do not increase the SVR in any way, especially with the use of very high pressures pneumoperitoneum. And it's interestingly, a lot of questions have already been generated in the chat box. And the first question I would like to direct towards Dr. Ketan. Dr. Ketan, Dr. Muthukumar Tajagopalan wants to know, what about thoracic duct injury in the left-sided brachiocephalic venous cannulation?
Yeah, thank you, Dr. Muthukumar, for that question. Per se, obviously, if there is anything coming and joining into the brachiocephalic vein, or you see some structure which is joining into the thoracic vein, in the brachiocephalic vein, you can assume that it is a thoracic duct. However, I have not seen personally anything coming and joining into the left brachiocephalic vein as till now. I might have done almost more than 200 brachiocephalic vein cannulations. Plus, I have not witnessed, or I have not come across any of the literature which suggests that there is a chance of thoracic duct injury. But just to be on the safer side, if you think there is something coming and joining the brachiocephalic, you can go on the right side as well. It's not like you can't go on the right side. It's just a little bit difficult, and that's what I told you. Like it was difficult for junior trainees. When I was working in Birmingham Children, they were using both sides depending on like where the ultrasound is. So there was There was no like any preference. It was just like where the ultrasound is, where you can put the ultrasound, they will use left or right, depending on the. So it is possible to use left side as well. Oh, sorry, right side as well.
Another question directed to you from Dr. Sumit Kalra. What are the common anomalies in brachial cephalic vein anatomy which are commonly encountered, which you should be aware of?
Yeah, this is a very nice question. Thank you, Dr. Sumit. So this is basically, suppose if you have common anomalies, I would say if you have left SVC. So then if you have a left SVC, your left brachiocephalic vein will not be there. So then again, you have very short brachiocephalic vein on both the sides. But again, if you are doing things under ultrasound, you will be able to see everything under vision, and then just again follow the same basic principle. Don't advance the cannula till you see where you are going, and then put the guide wire and everything under vision. So the philosophy remains same. It will be the view will be a bit different.
Another question to you by Dr. Muridhar Kanchi. He says that you have said that 50% of cardiac arrests in central line are related to pediatric population, and this is based on a report of 2007. Do you think it holds good even today?
Yeah, no, yes, I agree that it is 2007 publication, but we don't have any data from India, and there are no any subsequent studies which have basically which came up with the other like cardiac arrest. So that's what I could gather to put it in the presentation.
Okay. Another question to you from Dr. Muthukumar is, what are the complications we see in brachiocephalic annulations?
So similarly, as we see in other like subclavian or in IJV, if you are not like following the principles, if you are not looking at the tip can be somewhere else, and then it can puncture the posterior wall of the vessel. It can injure the artery. It can cause hemothorax, pneumothorax, all that stuff. But again, just because you are doing this approach, or just because you are using brachiocephalic, you are not immune to complications. You have to still go and use the machine very carefully. It's not the machine, or it's not the the brachiocephalic vein who is going to save you from the complication. It's finally you yourself who will be saving you from the complication.
Okay, another question has just come up. What are the cause of bubbles in the bubble test, and how are the bubbles safe to use?
So these I don't know exact physics, like how the bubbles are formed, but it's just, I think, simple agitated water as we see in bathroom, like when we are taking bath. So these are simple bubbles, and then bubbles are safe. Yes, these bubbles have been used, are being used, or they have the cardiologists are using them for very long time for diagnosing any shunts in the heart, ASD, VSD diagnosis. So it's not like something we have as an anesthetist. We are doing it. It's there. It's a well documented technique. We are just using it for like confirming that this is at the correct place.
Oh, can I add something to that? You actually the bubbles when we do this bubble test, it is not that we are introducing bubbles or air into the system. It is just the agitation of a fluid which creates micro bubbles, which are seen very easily in ultrasound. That is the reason why you see bubbles. It is not that we are causing something unsafe. Whenever you inject even IV fluid, if you inject IV fluid with the syringe, yes, and you look at the heart and look at the RA, you will find bubbles in the RA, despite the fact that you have not introduced any air into the system.
True. And just in case, just one additional point, just suppose if you are not very happy at looking at the bubbles, you can just put a color Doppler there, and you see the mosaic pattern, everything changes. So that is also a possibility. So
the next question is directed to Dr. Priyanka. Dr. Priyanka,
Yes.
Dr. Muridhar Kanchi wants to know where you talked about clonidine. So he wants to know whether there's any role of dexmedetomidine also in pediatric quarter blocks.
So there have been studies where they have used dexmedetomidine in caudal blocks, but actually, as far as I know, dexmedetomidine is not approved, FDA approved for this use in blocks, in caudal blocks, or in any other blocks. The only FDA approved indication is pediatric sedation in the ICU, and that too for I think 24 to 48 hours, not more than that. So that is why I myself have not used dexmedetomidine in caudal or even in the peripheral nerve blocks. I have only been using clonidine.
Yeah, thank you, Dr. Priyanka. I think that's the correct approach, because FDA has not till date, for last, though dexmedetomidine has been in the market for a long time, FDA has still not approved it for the use in either central neuroaxial block or in peripheral blocks also.
Yes.
So that's the safest way to do it actually. Though in India, people are using dexmedetomidine through all possible routes.
All possible.
All possible. Yes. And another question directed to you is what Dr. I don't know who the person is. It's what is modified Armitage formula? Somebody wants to know.
So actually the terminology modified I have not come across, but earlier what the Armitage scale used to be was that for the lower thoracic, they were recommending 0.75 ml per kg, but the spread is not good. So now they have removed that 0.75 ml per kg, and now it's 0.5 ml per kg, 1 ml per kg, and 1.25 ml per kg. So that itself could be the modified Armitage, because earlier, even when I was studying pediatric anesthesia or when I was studying my MD, I used to read 0.5, 0.75 and 1 ml per kg. But now it has changed.
Yeah, thank you. I think that's possibly the what is called as the modified drug, because it was 0.51 and 1.5 earlier. Yes. Another question directly to you by Dr. Kodandaram is that will rectus sheath block provide sufficient relaxation?
So not really. It is only for the analgesia, because as I said, these truncal blocks, except the quadratus lumborum block, it will not give any visceral analgesia. It is only for the somatic pain relief. So there is no element of analgesia, muscle relaxation as such involved. So it is a supplementary block to your general anesthesia. It cannot be used as your sole anesthetic technique in any ways. So it will just be for your analgesia purposes.
In between, one compliment for Ketan. Ketan, Dr. Sumit Kalra has complimented you for very convincingly showing how you can use a new technique like for cannulation. So he has complimented you for that. Okay, the next question is directed towards Jitin. Jitin, Dr. Muthukumar Tajagopal wants to know whether PD inhibitors like sildenafil be continued. How about bosentron, whether they should be used, etc. He wants to know whether you continue with sildenafil and bosentron, etc.
So, phosphodiesterase inhibitors are used to control the pulmonary artery hypertension, and they are notorious not only to reduce the pulmonary pressure but also the systemic pressures. So, there is a fall in systemic pressure during induction of cancer. So, it's recommended to hold the morning dose before we are proceeding with general anesthesia. But definitely, it's not really a strict line. But if you feel that if the patient is in PA crisis, or I would rather have an arterial line in place, a central line in place, and then decide my anesthesia strategy and not go by a particular declaration of using it or not in the perioperative settings. And it would be a balanced decision whether based upon the pulmonary artery pressures of the patients and the procedure that the patient is going to undergo.
Jitin, there's another question directed towards you. How about corrected congenital heart disease with residual shunts?
So we have to treat a dual shunt. The management would be almost on similar lines. It could be that earlier it was a big ASD, which is now a residual small tiny ASD or a tiny VSD. But of course, it would change from a balanced level of a shunt or a large unrestrictive shunt to a small level of shunt. We need to know when was the surgery done, what was the impact of the surgery on the current hemodynamics, the current status of the echocardial function, the pulmonary artery pressures, the current cardiac status, and then label it as a corrected small level of shunt, and then go ahead as presence of a small shunt.
Yeah. Thank you, Jitin. That was a good explanation. And let me tell all the viewers that it's very important to understand that in case somebody has had a heart disease in childhood, it is never permanently cured. you may increase, you may stop its progression by correcting the lesion, maybe like, closing the VSD, closing the ASD. But whatever damage has occurred because of pulmonary hypertension, which has happened before the correction was done, that remains. So that should definitely be evaluated, even whether it's a residual shunt or no shunt. You should always evaluate the functioning of the heart and the pulmonary system before you take up against whoever has a history of a congenital heart disease. That's a very important thing to remember. Remember that they say that it's only one disease, that is ASD, done very early in life. It does not have any residual effects. All other heart diseases have some residual effect on the body of the patient. So that's a very important thing to remember. There are no more questions. In case there are more questions, I would be very happy to take them, but it was, let me compliment all the speakers for an excellent presentation, for very concisely and very nicely putting forth all the salient features which are there on the topics which are there, which is, again, I would say, topics less talked about in pediatric anesthesia. And I'm very happy to state that the webinar was very informative. At least as far as I'm concerned, I'm very happy with it. I'm sure the listeners also must have been very happy with it. And with that, we close the academic part of the webinar. I'll hand over the webinar now to Dr. Yashri Sood, who will give her concluding remarks. Thank you, ma'am.
Thank you, Mukul. And you actually told what my heart wanted to say. And truly, we've had pediatric anesthesia webinars earlier as well, but this was out of the world. It was extremely informative, and we could again see that all our speakers who were there are, senior faculties who are doing this day in and day out, and that is why the videos and the explanation that they told us could surely showed us explicitly that they are so involved in it, and we all have learned a lot. And seeing the number of queries that were asked actually shows how interested the audience was. And I'm sure tomorrow as well, there'll be more queries coming up to us. And in fact, I would like to thank our speakers, Dr. Ketan and Dr. Jitin, of course, from Amrita. And Mukul, you are getting all the lovely speakers from your institute. Congratulations. And of course, Dr. Priyanka from Mumbai. Thank you so much, all of you, for having contributed to our ICA webinars. As I see, Jitin has, of course, been with us earlier as well. And Mukul, needless to say, you're always doing such a wonderful moderation. You always, raise the standards of the webinars, and no wonder you are such an important member of the ICA. So I'd like to thank all of you, and just to remind you that next Wednesday is also another very important topic, and this is about spinal anesthesia. How can it be different? So this will be also very interesting, and I request all of you to join. And so with this, I wish you all a very Merry Christmas, and see you all next week. And thank you so much. Dr. Radhakrishnan, thanks a lot. Dr. Muralidhar Kanchi for being there. Mukul, Ketan, Priyanka, and Jitin for presenting this webinar. Thanks a lot, and good night, everybody. Thanks for us, and we'll see you next week.
Good night.
Thank you very much.
Good night.
Thanks a lot.